So we are live now. Very good evening and welcome everyone. This is Arpita from the IGCP group. Welcomes all to the session, to the webinar on the topic Immune Reconstitution Inflammatory Syndrome, which is the IRIS. So immune reconstitution inflammatory syndrome is a medical condition observed in individuals undergoing treatment auto, for severe immunosuppression, such as those with HIV/AIDS or after organ transplantation. It occurs when the recovering immune system mounts an excessive inflammatory response to existing infections or antigens. This paradoxical worsening of symptoms can complicate treatment, requiring careful management to balance immune recovery and inflammation. To address the topic, we have with us a very expert person, none other than Dr. Uday Kumar Jadhav, sir. It's an honor for me to welcome sir to our platform and to introduce him to everyone. Sir has done MBBS, CHIV, PDCR, AFIH, infectious disease consultant. He's in charge of Art Center and LNT, MD ACS Mumbai. He's the owner of Life Care Clinic, Total Care in HIV/AIDS at the Aurangabad, Maharashtra. He's attached to Panacea Specialty Hospital at Aurangabad, Maharashtra, and also he's a consultant at the Shraddha Hospital and Critical Care Center. So with this very brief introduction of sir, I would now request him to please start with the topic. Over to you, sir.
Yeah, thank you, Arpita. Good afternoon, everybody. Uh, I'm happy that you have joined today. What is a wonderful topic, that is immune reconstitution inflammatory syndrome, also abbreviated as IRIS. IRIS is not the same as we see what the eye has within, but this particular IRIS constitutes of some kind of interesting workup when we see a patient with HIV. I'm Dr. Uday Kumar Jadhav, and let's begin with this particular topic. So, what is IRIS? Before giving the definition of IRIS, we should know that whenever a patient who is having a seropositive status, who has been diagnosed with HIV, when that person is under you or being treated in the hospital, there can be few things which can have a retaliation with the patient's relative as well as the patient himself. We have seen that once a patient is getting treated, we have diagnosed it correctly that there are some kind of opportunistic infections, and while while treating the patient, we are abiding by all the rules and regulations, but still there are some incidences where the condition of the patient can worsen. And this clinical worsening, or when the laboratory parameters, despite of having a favorable outcome, have differences in an immunodeficiency patient, then we call this as IRIS. So a paradoxical worsening of the situation of patient when the lab parameters are becoming favorable, we call it as IRIS. So a lot of times patient's clinical condition can worsen. That can be due to virological failure, clinical failure, or other kind of conditions which can trigger. But there are few conditions in which when the patient is started on antiretroviral therapy and both infective clinical or subclinical conditions can act triggering factors which are precipitating for the condition of immune reconstitution inflammatory syndrome. So today's topic is little bit atypical, but one should have a proper knowledge of IRIS while treating a patient with having a HIV status. So how can you diagnose a particular patient with IRIS? For this, we have some major criteria and some minor criteria. The major criteria for a patient who is having iris is that atypical presentation of opportunistic infection or tumors in patient responding to antiretroviral therapy. So, if a patient is admitted who has been diagnosed as tuberculosis, and after we have started with the antiretroviral therapy, we also started uh, after started with the ATT, and we also started ART, and then we see that when there is changes in the viral load as well as CD4, then there can be changes in the iris. The major criteria is the atypical presentation of operative infection or tumors, and also second is decreasing the plasma viral load by at least one log that percent. What about the minor criteria? Yes, there are few minor criteria in which if there is increase in the CD4 count, so after starting of the hard, highly active antiretroviral therapy, increase in immune response, especially to relevant pathogens, and spontaneous resolution of disease without specific antimicrobial therapy or tumor chemotherapy with continuation of antiretroviral therapy. These are also some criteria which can be seen in the iris. So, iris is something like a puzzle which can come up, and then the patients' relatives, as well as doctors, they are confused. So, what can be the presentations that are seen in patients with iris? So, the clinical features of iris differ according to the inflammatory or infective pathology. This is possible due to the underlying reasons that are causing. So the various presentations include the non-infectious syndromes, and in which we have with criteria with the cutaneous involvement and without the cutaneous involvement. As we know, skin is one of the largest organ of the body, and also the knowledge of having the proper proper visualization of the skin diseases, we can understand what are the criteria that can be. So all over the world, we have found that if there are papular urticaria, if there is eosinophilic folliculitis, if there is sweet syndrome, Rieter syndrome, sarcoidosis, SLE, or Peyronie's disease, definitely it can be added in patient of HIV. And without fitness involvement, we can have autoimmune thyroiditis, Guillain-Barré syndrome, myopathies, radiculopathy, acute porphyria, NHL, and Castleman disease. So there's these two criteria I've seen, and we need to find out what kind of presentation that is the patient. So the patient, when we have admitted in a hospital, and most of the time can be diagnosed with the OI. Most common patients who come late, whose CD4 count is less than 50 cells, can have oral candidiasis, tuberculosis in Indian settings, and in the Western setting, there can be non-Hodgkin's lymphoma, Hodgkin's lymphoma, or other kind of OIs related to the patients. But when the patients started with treatment of the OI and again started early treatment of the ART, definitely there are chances with the weak human status, person can have a rise in the CD4 or depth in the viral load, causing iris. There is a paradoxical worsening of the clinical condition of the patient. The clinical manifestation of iris constitutes some common OIs. Let's see them. Number one, commonly the tuberculosis, what we diagnose. We do most of the time in the patients having HIV, the tuberculosis can be sputum positive, but minimally. But in my maximum times, we have uh, non-sputum positive patients which are having tuberculosis of organs like the abdominal tuberculosis or like spinal TB or spine, or we can also have cerebral TB in that. So if a person with tuberculosis has iris, then after 1 to 6 weeks, that or within 1 to 6 weeks, the we had to started. The signs of severe tuberculosis iris. It can include high fever. There is worsening of lymphadenopathy. It can be mediastinal or peripheral. Worsening of pulmonary symptoms. And we can see few infiltrates or increased pleural pressure or even brain signs can be seen. Lymph node abscess is usually commonly seen during the first week of highly active antiretroviral therapy. So if the patient is having worsening symptoms, what we can think? We can think that if this might not be tuberculosis. This might be resistant to the drugs or drug-resistant tuberculosis, or this can be some kind of other infections like Hodgkin's, non-Hodgkin's lymphoma or other things. So while diagnosing the opportunity patient, we should be particular. And after diagnosing, we should be confident. And we should keep in mind that this paradoxical worsening can be iris. We need to diagnose it more properly. What are the extrapulmonary presentation we have seen? Extrapulmonary symptoms, we can have expanding lesions in the central nervous system or skin, or we can have some kind of abscesses. There can be osteomyelitis, nephritis, meningitis, sometimes hypercalcemia, hepatosplenomegaly, or epididymoarthritis. Some patients also have presented us with psoas abscess and bowel perforation. So we need to be careful to understand what the basic pathology is lying, why these changes are there. In one study, 4 out of 5 patients who had clinically developed atypical microbacterial infections after heart and significant improvement in CD4 cell showed significant increase in MAC specific T cell response in vitro, proving that this phenomena is indeed caused by the unmasking of subclinical infection. So whenever there are 1 or 2 or more infections in a particular person, and when one of the infection is not treated thoroughly, and we start with the antiretroviral therapy, the immune cells try to burst up to clear the other kind of infection, which flares the second infection, causing iris. So iris is something we need to study. We need to be cautious about. We should keep in mind just finding opportunity infection and treating with antiretroviral therapy or having a grudge of starting antiretroviral therapy as soon as possible is something is not recommended because this kind of subclinical infection may flare, which can also lead to a lot of confusion to patient as well as the treating physicians. Pituitary meningitis is also one of the things we commonly see. So in crypto, we usually see in 1 week to 11 months after antiretroviral therapy. In patients with or without previously diagnosed cryptococcal meningitis, presentation of iris in the cryptococcal includes fever, headache, lymphadenopathy, and meningitis. The cases of iris, the MRI usually shows choriomeningitis with significant enhancement in the choroid plexus. Typical antigen in the CSF is positive, although culture remains negative. These are the typical findings that we see. Most of the times, what happens in crypto, if you do not give the dose of the antifungal agent for a proper period of time with a proper specific indications of treating that time, the dose doesn't go well. Sometimes there are issues with the kidney, or the issues with the liver, and these political things also cannot put up. Sometimes there is resistance with the patient in which the cryptococcus is not properly treated. And if we start the treatment of heart at the same time, then definitely these things can flare up, leading to a lot of other kinds of. So if you see the differences in the differential diagnosis of what is the failure of ART or is a paradoxical failure, then we have to be very smart, understanding how and what can be the things. Number one, if you want to find out if there is a failure of ART on toxicity, we have to see active OI, opportunistic infection, and failure of the antimicrobial therapy are considered in the differential diagnosis. We should know what is it, failure of ART or toxicity. So that should be found out. Then secondly, if there is failure of ART, it can be ruled out, which is decrease in CD4 count, increase in viral load, and along with clinical deterioration. So we should see the signs and symptoms of the patient. We should observe the patient clinically, and we should find out if this is an active opportune infection that is ruled out while assessing the pathogen. The WHO made an important distinction between iris and clinical failure while on anti-HIV therapy. So when we watch closely, definitely we think we can find. So clinical failure is defined as clinical disease progression with development of an OI or malignancy when the drugs have been given sufficient time to induce a protective degree of immune restoration. That means if a patient is on treatment and is given proper treatment for a longer period of time, then definitely iris is a less likely diagnosis. Clinical failure can happen due to non-adherence of the drugs, due to failure of the drugs to maintain the proper level in there. This can be caused due to drug-drug interactions. It can be caused due to other situations when there is resistant to the drugs, and therefore we should know how and why the patient is taking the treatment. Is the patient taking the pills under some proper guidance from medical person? And also there are some ways in which we need to understand that immune response syndrome, it can be seen in first several weeks after the institutional therapy. If something is present at the baseline, this can flare. So the first thing, whenever a patient comes to you wanting treatment for HIV, who or his relatives might be very much feared up. This can be due to the stigma attached to the disease. This can be to the various issues of HIV that are there in the society. But we should be non-judgmental. We should be neutral. And first of all, before starting or initiating ART, we should find out what kind of approaching infection the person is suffering from. For this, we need to take a good history. Yesterday, uh, I was with a seminar and found out that the new doctors, they are not trying to get to the detail of the history. Just, uh, just as what you call it, they are leveling themselves on the basis of what the patient is saying. We should be beyond the words of the patient. We should be correlating with the clinical presentation of the patient, also with the work of the patient, with the questions of the patient, and the history of the patient, and taking a proper history. Well, we should also be asking the past manifestations of any diseases. People also try to hide, to do look sober in front of you. They're uh, yeah, they to have their habits like alcoholism, like having what you call smoking, tobacco chewing. These things which may or may not be normal for them, but for understanding us, we need to know what kind of issue they. So that thirdly, we should also ask about the sexual history. What kind of preferences they have in their life. Now, as you know, syphilis is coming up, and also gonorrhea is also coming up rapidly. So these particular infections, which were thought to be extinct from the medical history, they are coming back. Now, as we know, the virus is being treated properly with the new antiretroviral therapies, but that doesn't mean a patient with high viral load will also react to the same kind of protection against the immunity in this person. So if a person is having high viral load and we start and also some kind of opportunity infection, we start the treatment with proper workup, definitely there can be few chances in which we can have condition like iris. So we need to be very particular while treating the iris. We should be aware of the opportunity patient that can present. Not all patients know that they are harboring any other open infection other than HIV, and therefore this can lead to a situation in the future. So the most culprit in HIV diagnosis of the OI is the PCP pneumonia. As we know, we do not culture PCP pneumonia, nor do we have any kind of antigen antibody test to find out the PCP pneumonia. So how do we diagnose PCP pneumonia? PCP pneumonia is diagnosed by the X-ray or the symptoms of the HIV. So when a patient is not able to breathe properly, when the saturation level of the patient goes down to 70% suddenly, patient is not able to walk up two stairs, two level of stairs, and patient cannot breathe properly or gasping, then definitely there are higher chances of having the PCP. These are the clinical features. What about the X-ray features? Here, X-ray, we are seeing ground glass appearance CT scan, also in X-ray. Therefore, to find it out that this particular criteria can lead to is part of PCP pneumonia. And this particular patient of PCP, they need a high-end treatment exposure, high-end treatment environment. They need to be admitted in the ICU so that we can get the best treatment of that. And only 75% of patients with PCP get treated or get a positive outcome, 25% do succumb. So PCP is having a high mortality, and that is due to non-diagnosis or inadequate diagnostic facility in situation. CT scan is the best guide to find out the patient is suffering from PCP or not, and what kind of treatment we should be giving. So in iris, if the patient worsens, then the pulmonary symptoms, the patient can have high fever, and patient who will improving on PCP patient, they show worsening in the lung involvement, and also the oxygen saturation or arterial blood get like they go down, hypoxia is there, or the alveolar arterial gradient goes down, and therefore we need to find it out. Which patient can go in acute respiratory failure. We might need to intubate such patients, keep on ventilator for few days and work on that. But when you are totally sure that yes, this is iris, it is not a failure of treatment, then we can work up with the relatives and patients can do a better job. So to finding out better treatment options for the patient is the direct work of hard work of the physician who looks in the matter, who not only has to treat the patient, but also has to consult the relatives, in which we get the best chance to make them understand this. Few of the times, the relatives may be more worried than you, as that one person can be a earning member for the family, support the family. But when a person comes in the late stages, there are issues which we need to explain forefront to the people that this kind of workup can happen, and if they are treated properly, definitely we can have a better outcome in the future. Same goes with the CMV, cytomegalovirus. As we know, cytomegalovirus happens in people who have a CD4 less than 50. What is cytomegalovirus? It's a virus that attacks the organs like the retina, the lungs, and even the abdomen. Very low clinical conditions like no fever or anything else. Only this for a diagnosed CMV, we have to suspect CMV. The CMV can, as we know, can come from cats. These are the commonest mammals which are near humans, and this can be served. CMV, when it is in the any person, it remains dormant for a lot of time, for more major time. It can live there for 10 years, 20 years. And while remaining in the dormancy, when the immune system is disabled or the CD4 goes down to 50 or down, then we can have symptoms. If it's affecting on the eye, causing retinitis, there can be diminution of vision, there can be peripheral vision, and also patients may have some other phases. So there can be vitritis, uveitis, and the people started with antiretroviral therapy, then there can be a lot of commoners part in that. So CMV hepatitis typically will present with acute onset of blood vision. That is, there are floaters, they are floating in there, and caused by posterior segment inflammation. Ophthalmic examination reveals numerous inflammatory cells in the vitreous humor. Symptoms usually resolve in 1 month without specific treatment and without any lasting visual effects. If the person having CME, uveitis, and iris, then when the ART is initiated, there is a late complication of this, and it occurs about 3 years after patient begins ART. It often results in macular edema, epiretinal membrane formation, and or cataract, which can lead to permanent vision loss and hence require high index of suspicion. So high index of suspicion is the prime part to find or to detect the iris. So if you have a suspicion for iris, definitely you will catch it up. But if you do not, then definitely there is a less chances of getting into part of this iris. So now we come to the treatment of iris. As we know, we have talked about it that this can affect one part and get inflamed or flared up in other part. So treatment of iris, what kind of treatment of iris is there? So as you know, there are no standard guidelines for the treatment of iris, and following interventions are mostly based on published cases, reports, and other anecdotal clinical evidence. Treatment includes continuation of the primary therapy. That's very important. The fourth thing is we have to continue primary therapy against the offending pathogen in order to decrease the antigenic load, and also the continuation of the effective heart and judicious use of anti-inflammatory agent. So whenever we have, suppose the person is having tuberculosis, and then the person flares up, then what we have to do, we get some kind of pulse field lymph node, or we get some CNS infection out of that. Then what we do, we continue the treatment. We use continue the heart, and we use steroids. These steroids, when used, they act well, and it takes time. Yes, it takes. Iris doesn't get cured in 1 day or two. Depending on the type of the body affected, part affected, the iris can extend. The treatment of iris can extend up to 1 year to from 1.5 months to 1 year. So I have treated patients with TB iris for 1 year, and then they got better. But the issue comes from the, what do you call it, the suspicion, then the faith of the doctor in his conviction that this is iris, and secondly, the patients who rely on the doctor or who have faith on doctor, which definitely can give us the best result. In the milder case of iris, we continue the heart, the antimicrobial agents, and also the NSAID drugs. This help them to get the results. So in the serious or severe life-threatening iris, we need to start with the oral prednisolone, which is about 42 mg per kg body weight. The exact duration of dose of steroids variable and depends on the clinical severity. Sometimes the duration of the steroid therapy may extend to 6 months or 1 year, as I told before, and consider discontinuation of heart in case of severe life-threatening iris. So we had discontinued a lot of people from the heart when we have ARDS or encephalitis, cerebritis, or perilesional cerebral edema. We need to consider, we need to stop the therapy, we need to wait, and definitely after few days, the inflammation goes down, and we can also have a problem. The patient with iris have better outcomes, but we need to find out the way it has progressed and find out how the disease has come about. So the approach iris doesn't require any modification in the treatment of OIs. Maintenance treatment for OI should not be changed, and previously completed OI treatment for tuberculosis should not be reinitiated. Similarly, the dosage of chronic suppressive treatment for the OI should not be increased. We should see them and treat them as per the infection, as the treatment, as per the clinical equipment. And we have to find out the best way how the patient can be survive. Now, after the treatment of iris, we should come to the word how can we prevent iris? The first way of prevention of iris, we need a high index of suspicion for diagnosis of iris. That we should know this particular thing is iris. Then we should have a detailed clinical history for the patient, and we should also include following symptoms. Like we find out that what the symptoms commonly seen the fever, cough, or any specific symptom. History of operating infection. We should know what kind of infection in the past 6 months, 1 year, 10 years he had. Maybe he was diagnosed HIV last month, but prior to that he was HIV positive. So we should know what kind of other history that he can add to. Secondly, sexual history. What kind of sexual preferences he had, how they were treated, how they worked up. Did he have any kind of STI in the past? Or also we need to know what kind of operating infection were there treated and diagnosed. Was he a defaulter? How was the adherence of this? How was the duration of the therapy? How was the clinical response? Resistance, ART initiation date, regimen that was used, what was the adherence, and also the prior history for ART toxicity in drug interaction, CD4 count, HIV viral load, prior to ART initiation, and also in between. So these kind of things we need to get to details. We should be on tiptoes, find out the details, and get the person treated. Also, we have to look for vital signs like temperature, heart rate, blood pressure, rate, and I perform a careful and thorough physical examination based on the symptom and suspicion of the symptoms involved. Ophthalmic examination should be included in all patients. Most of the time, ophthalmic examination is not included. Most of the patients feel that my eyesight is good, so what should I do? But a lot of times, while doing the retinoscopy, we found out new things, we diagnosed new things, and therefore we should be very much interested in doing the ophthalmological examination. The commonest exam investigation that you should be done after starting the ART is first we have to do CBC to find out how the cells are. Then we have to do the ESR, the serum electrolytes. We also liver function test and renal function test, CD4 count and HIV variant. As we know, in our Indian treatment workup, we go for government. Government is not doing CD4 count now. They are only doing a HIV viral load, and that too once. So, but a person, when under treatment admitted, we first should know what was the prior CD4 count and the CD4 count when the patient is admitted for treatment. We should also go for chest X-ray, Montus test, Putum hand sculpture, and also ultrasonography of the abdomen. In a suspected case, even initial negative, Montus negative positive could be suggestive of iris. So a lot of clearing of this. Iris is actually inflammation of the cells. Inflammation of the cells can lead to the inflammation of skin and some kind of effect on the body. So to conclude, we should be seeing this that patient was started on ART of CD4 count less than 100 cells per microliter require a close clinical monitoring during the first weeks of ART. Similarly, they should be counseled about the risk of development of iris to avoid being discouraged and defaulting therapy. As development of iris suggests increase in the immunity and is a good sign unless life-threatening. So, whenever patient has iris, we should give him some kind of example where we say that when a patient started with ART and patient gets some kind of worsening of symptoms, there can be a good sign. As CD4 is rising up and virus load is going down, we should stick to the plan, make the patient understand, give them anti-inflammatory drugs, and keep a close watch on these people who, after a good treatment, definitely will success. In my experience, I have treated about a lot of patients who had iris, a lot of patients who had dental infections or dental failure, and we had a good result of iris. So I would suggest people or patients who are having a low CD4 count should wait if they are diagnosed with operating infection to get rid of symptom first, and then the treatment would work out finally well. So this is iris in short for you, and iris can be worked up properly if that was diagnosed and treated well.
Thank you, sir. Thank you so much for the beautiful presentation. Let me see what are the questions that have come in between.
Yeah,
Yes, sir. The first question is, how should treatment regimens be adjusted in patients with iris to balance immune recovery and inflammation?
yeah. So first of all, we should diagnose the opportunistic infection. And when the opportunity infection diagnosed, we should also know that there can be subclinical infection that is there. So if you, we should not be in a hurry to start the antiretroviral therapy. Antiretroviral therapy started only when the symptoms of the first opportunity infection they are reduced or as negligible as the patient can mention. So a patient who is having tuberculosis, most common OI diagnosis in India, or we should start the ART only after 1.5 months of the treatment of AKT. Why? Reason number one, their AKT also has own side effects leading to hepatitis or other kind of CNS symptoms, very much possible. And even antiretroviral therapy started with the same can give or flare up some kind of infection with them. If, so we need to see what kind of infection is there. Definitely, we should go for diagnosing retinitis in the patient. The ophthalm examination is a must. A good ophthalmologist or good retinologist is definitely a boon for a practice. And we should be starting with a simple part of the ART. And then, when the ART is tolerated well, we should see how can we deal with the other things.
Thank you so much, sir, for answering the query. Next question is, are there any preemptive treatments recommended for patients starting the ART?
The prerequisite for starting the ART, as I mentioned in the conclusion, we should first see the all the blood investigations there in proper way. We should go for at least minimal X-ray and a sonography. While doing a sonography, we should ask the sonologist to find out if we can find some kind of unusual lymph nodes or pus in the abdomen, which can be a good hint for finding out the opportunity infection for extrapulmonary tuberculosis. Also, we should see or we should get the best history of the patient, which may take some more time with the patient when finding also doing a clinical examination. Most of the times, while seeing a patient of HIV, people or doctors are reluctant to get the proper history. We should see all the orifices of the patient. We should see a detailed examination in the oral cavity. We should go for the history of the habits history, which can give the type of work the person does. And these particular things, we can find out what other kind of infection one person can have. So cutaneous infection and otherwise can be definitely diagnosed and we can find out the proper way to treat the patient. So as I told, good taking good history, good proper examination will lead to a proper diagnosis and proper treatment.
Right, sir. Right, sir. Thank you so much, sir. This is the last question. How do symptoms of iris vary depending on the underlying opportunistic infection or the condition?
Would you please repeat it? I just missed it.
Yes, sir. The question is, how do symptoms of iris vary depending on the underlying opportunistic infection or the condition?
Yeah, definitely. So, opportunistic infection is the key part for the iris. So if you are having tuberculosis, if it's extrapulmonary tuberculosis, then definitely that infection from the abdomen can have what you call other kind of complication of the abdomen. If you have a CNS TB infection, definitely that can flare up to for some kind of edema of the brain, and the symptoms of edema of the brain can happen. If it is a ophthalmological condition of optic vision, as I told you, retinitis can go to uveitis. So this is a spread of the thing due to the inflammation. So diagnosing the opportunity infection is the key part. For that, we have to take a good history and good clinical medical examination of the patient. If we go with this particular criteria, we can get the thing. Most of the times, good history will help. I will just cite an example for you. I had a patient who was very much worried that she was HIV positive. So I admitted the patient immediately as the husband was very anxious and she was also very anxious. After admitting the patients, I had to go to a seminar for 2 days, and for that my colleague was seeing the patient. And when my colleague had gone to round, the patient, while talking with she was female colleague, talking with the patient was a female. She told that, Madam, I couldn't see your face properly. Maybe I'm missing your face. Why don't you come to near me? I can see your face. He was a 35 years, 40 years female. And then when that thing was explained to me, I suspected this is CMV retinitis. And definitely the person is not knowing that she is having CMV retinitis. The patients do not directly tell everything what they have or suffering from that on the day one. So the history taking process, the continuous process that begins when the patient lands in your clinic till the patient exits from your services after the admission. So taking a detailed history is the best criteria. In India, we cannot afford detailed investigations as in the Western countries. We need to be very much what do you call it, reliable on the history. And as the patient most of the time cannot afford all the investigation, we have to find a base in which we can find the best suspicion and get the medical suspicion in the patient covered. So if we can do that, definitely we can find out what kind of infection there can be. And so being curious is the only criteria in India to find out the proper investigation to treat the patient, know the diagnosis and treat the patient.
Right, sir. Thank you, sir. We have received another question meanwhile.
Yeah.
The query is, sir, as you have mentioned, like patients who are on alcohol or who take cigarettes or on smoking, it becomes difficult for them to manage. So, along with the treatment, do we go for psychological counseling or rehabilitation for such patients, or we just need to continue with the treatment?
Actually, as we know, having alcohol or having a habit of alcohol can lead to liver cirrhosis, liver toxicity, and also liver cancer. Also, smoking can lead to pulmonary cancer, pulmonary infections, and cancer. So, this particular criteria, we need to find the aim of the treatment for ART or for HIV positive patient is that we should extend the lifespan or have a healthy lifespan. And if a person is being judged for this, we need to go for some kind of counseling. The psychological counseling helps the person to understand the need of having some kind of habits like that. Maybe there can be stress, maybe there can be fun, maybe there can be a peer pressure that is making the person have this. So going for psychology counseling definitely would help it. But number one criteria before that is identifying the habit. Most of the people say that yes, I am just having beer, and beer is not something like, or even having wine, and even doctor prescribe wine. Doctor asked to have this, so they try to hold their decision with some kind of what do you call things which can support their thoughts. So any person who is having such kind of habits, we know, can lead to some kind of healthy hindrances in the future. And for that, we need to be careful. And people who are habituated for such things, we need to see that they get a proper help. That can be done by the doctor himself or by a psychological counselor. But getting the best for the patient should be our aim while treating a patient.
Thank you, sir. Thank you so much for answering all the queries that have come. Sir, as there are no more queries for today, so we would like to conclude the session here. Sir, I hope you have also enjoyed the session.
Yeah.
Yes, sir.
So
So,
you have two more queries. Hello.
hello?
Yeah. So two more questions are there. Is that what you're telling me?
No, sir. There are no more queries. So
No
we
more
can
queries. Okay. Okay.
no, sir, no, sir. Sir, so with this note, we would like to conclude the session here, sir. I would like to first of all thank you for giving us your precious time, and of course to all the audiences for joining us and to make the session a successful one. Thank you, sir. Thank you so much.
Thank you, ma'am. Thank you.
Thank you. Thank you, sir.